Next
Greetings,
lecturer
Professor
is
Maria.
hello,
Hello,
namaste,
Professor. Namaste.
Dr. Sivaraman.
Yes, Professor.
Uh, Thank you for your contribution. Dr. Sivaraman is associate professor in the Department of Prosthodontics in Manipal College. Uh, he talked about zirconia versus titanium in oral implantology. Please.
Yes. Thank you, Professor Maria. I'm just starting with my presentation. So I would be talking on this topic, zirconium versus titanium, dental implants, an evidence-based update. So we already know that titanium is an established implant material, and it has been used for treatment of cases with wide variety. Like even if it's a single missing teeth, or it's a couple of missing teeth, or it's an extensive rehabilitation, we do use titanium, and we know it's quite predictable and quite safe to use, with good survival and success rates reported. So now we are coming across zirconium as an, or zirconia rather, as an emerging alternative to titanium. So what we need to find is this material with comparable mechanical properties? Does it have good biological properties? Does it have good aesthetics? How does it perform in compared to titanium? Is it really going to take over titanium in the coming years and become the mainstay of dentistry? So we will be exploring all these aspects in the presentation. So first and foremost, we need to understand that in the periodic table, the titanium and the zirconium are located quite close to each other. And as a result, they will share similar properties. And they both are transition metals. So when we talk about titanium implants, they're basically fabricated of titanium alloys or commercially pure titanium. So when I use the term alloy, it means we are combining different metals. So when in an alloy, we will see metallic bonds between the elements, and there will be free electrons, and as a result, greater electronic conductivity. On the other hand, when I talk about zirconium implants, they're basically fabricated of a zirconium dioxide. So it's a combination of zirconium with oxygen. So we will be seeing an ionic bond and properties which are not conforming with that of an alloy. So what we need to understand and reinforce is zirconium metal is not the same as zirconium dioxide, also commonly known as zirconia. So we already understood that zirconium dioxide or ceramic oxide is not similar to a metallic alloy. For instance, we know that titanium and zirconium are combined to form a rock solid, which is a metal alloy. But we find zirconium dioxide is not a metallic alloy. So the applications and the physical properties will vary. The other important aspect is there are a lot of discussions regarding how zirconia is gradually being increasingly used by clinicians. However, when I came across this survey, it's based in the US dental implants market. So currently, the global dental implants market is valued at around $4.9 billion. And if I look at the US dental implants market, we see a growth projection chart, and it projects a 10.2 compound annual growth rate from 2024 to 2030. Of interest, however, is that even though the amount of implants being used is forecasted to increase significantly, titanium's implants do remain the mainstay and are not being increasingly replaced by zirconium. Even though the margin of zirconium has increased, it's not going to replace titanium in the near future. So initially, when we were using ceramic implants in dentistry, we were mainly using alumina, but they were removed due to poor mechanical properties. So zirconia in its pure crystal phase has three phases. It has monoclinic, tetragonal, and cubic. So the monoclinic phase exists up to a temperature of around 1170 degrees Celsius. The tetragonal existing to a temperature of around 2300 degrees Celsius, and cubic existing above the temperature of 2300 degrees Celsius. Now, when there is a transformation from the tetragonal to the monoclinic phase upon cooling, there is a volume expansion what is seen, and there is a propagation of crack, which can result in adverse mechanical properties of zirconia. So to avoid that, there was a series of stabilizing oxides which were added. common amongst which is yttrium oxide. So that resulted in a martensitic like transformation toughening for the material, and is the main reason why the mechanical properties of zirconia are improved compared to its predecessor alumina. However, we also need to understand that under certain manufacturing conditions, especially under exposure to moisture and stress, there is a transformation of this tetragonal phase to monoclinic phase from outside to inside. And this is in form of a crack propagation, which will result in reduction of the strength, toughness, and density of the material. So this will result in adverse consequences for the properties of the material, which were supposed to be enhanced in the first place. So this is also known as aging. So to improve the durability and stability, alumina had been added later, and this is known as tetragonal zirconia polycrystal with alumina. Now, in vitro studies have found this evidence for aging, but they are found to be within the clinical acceptable limits. However, the concern for us is there are various manufacturers for zirconia, and most of them do not have a clear R&D. What I mean is the clear process of manufacturing and the conditions. So if you are using an implant from unverified manufacturer, who does not provide a data, you can have troubles later with the implant during clinical use. So when we talk about the mechanical properties, the modulus of elasticity is very frequently spoken about. So we basically desire an implant material which will have an elastic modulus closer to that of bone, because we want the stresses to be distributed uniformly and less disturbance at the bone implant interface. So when we look at the values for the titanium alloy, which is frequently used, its elastic modulus is 110 gigapascal, which is higher than human bone at 10 to 30 gigapascals. But when you look at the values of zirconia implant, which is yttrium stabilized, it is around 210 gigapascal. So there is a considerable difference. Now, when we have an elastic modulus which is closer to that of bone, we do not see any stress accumulation within the implant. When we take an implant material which has a greater elastic modulus and greater difference compared to that of bone, you will have a stress shielding effect which is seen, and as a result, the implant material will be prone to fracture, and it will also result in a altered bone remodeling process. So if we analyze this data objectively, we see that the titanium alloy has much favorable result over a long term due to this major difference. Also, when we talk about an implant, we want it to be biofunctional. We do consider the properties like tensile strength, compressive strength, fracture toughness, yield strength, fatigue strength, and ductility. These are all important for the biomechanical component. And titanium alloys do fare better than zirconia in this aspect. But why are we concerned about the mechanical properties in the first hand? That is because the mechanical properties influence the design of the implants or the treatment protocol. And we would be looking at how. For instance, we mostly practice two-piece implants. And in two-piece implants, the abutment is tightened onto the implant body. And that is possible because of the elastic deformation which is happening within the screwing material as well as the implant body substrate. So if it's a titanium two-piece implant, both the screwing material and the implant body substrate are of the same material. However, when we are using a zirconium implant, if we use it in a two-piece manner, we know that zirconia has a high elastic modulus. So there will be a greater resistance to such elastic deformation. On the other hand, its fracture toughness values are relatively low, so it can fracture in thin cross sections. So that is the reason the zirconia implants were initially introduced in one-piece form to avoid this weak implant abutment interface. Even subsequent two-piece zirconia implants prefer this interface to be of chemical bonded rather than having internal threads for micromechanical retention. So this is one aspect how a mechanical property will influence the design of an implant. What else? Now, when we place an implant, we know or prefer that we place it in a position whereby there is no early loading of the implant during the healing phase, because it can impair osseointegration or the bone implant contact. However, when we place in one piece zirconia implant, there is a greater probability of early loading during healing phase and compromise osseointegration. Also, when we talk about a two-piece implant, we know that there is a hollow slot in the implant body. Now, when there is a stronger metal like titanium, you can make it in thin cross sections. Or if the bone availability is less and you cannot consider surgical options, there are narrow diameter implants. However, when you consider zirconia, studies have actually recommended against using narrow diameter implants. And since we know that the mechanical property is not as good as titanium, we cannot take the risk due to adverse results. So moving on from mechanical properties, the next important property is optical and aesthetic properties of titanium and zirconia. So zirconia is highly perceived as an aesthetic material amongst the clinicians. And in this case, like we can see, you have a grayish hue, resulting in perceived poor aesthetics in patients, especially with a thin tissue biotype and high smile line. So we need to actually contemplate whether is it the titanium which is lacking aesthetic, or in this case, is it the lack of appropriate treatment planning? Did the clinician actually consider the tissue biotype? Did he or she consider the smile line? Did he or she contemplate any adjunctive hard or soft tissue grafting procedure? This kind of aesthetic complications can also be seen in cases where immediate extraction and implantation has been done, whereby where technical expertise is very important. So we do know that as clinicians that zirconia implants do look aesthetic, but what is the perception of the patient? So here is a publication which was done by Gallert et al., where in around 2018, in which they conducted a study which was conducted in Basel as well as Munich, and around 30% of the patients in Basel preferred ceramic implants, with a high number of around 53% preferring ceramic implants in Munich. And the preference towards ceramic implants were mainly motivated from the perspective of aesthetics. So in this case, the patients also tend to incline towards ceramic implants, thinking they are going to get an aesthetic treatment. So first we had a look at the mechanical properties, whereby the titanium was felt to be superior. When we looked at the aesthetic properties, zirconia had a greater aesthetic result. So moving on to the next important part, which is biocompatibility. Now, when we talk about biocompatibility, it's about the chemical reactivity of the material. Now, titanium element itself is extremely reactive, and it forms a surface layer of titanium dioxide. Now, this titanium dioxide, even if it's scratched and removed, tends to repair itself, which results in an kind of an impression that it's very passive in nature. And this is the reason why it is supposed to have a high corrosion resistance, and there is an apparent lack of safety issues in the human body. But the important question here is corrosion is a good corrosion resistance responsible for the biocompatibility with surrounding hard tissues, or there are additional factors? What I mean here is, if a material is very exhibits a very good corrosion resistance, does it mean that it's very biocompatible with the surrounding tissues? The answer is no, because there is gold, which is an extremely corrosion resistant metal, but it's found to be inferior in tissue compatibility. Studies have also shown that in order to increase the corrosion resistance of titanium, when platinum was electrically plated onto it, it did improve the corrosion resistance, but it reduced the bone formation. So moving on from the titanium oxide, we know that there is a layer of titanium oxide formed over the surface of titanium. Now it does react with the moisture present in the air to form hydroxyl groups, which will subsequently form electric charges upon dissociating in aqueous solution, like body fluids. So depending on the pH of the surrounding solution, these charges are balanced between positive and negative at a certain pH, defined as the point of zero charge. So basically, the point of zero charge is a gauge of acidic or basic property of a surface oxide and will vary with the material. So when we look at the PZC value for rutile and anastase, which are crystalline phases of titanium, we see that it exhibits almost a neutral property. There is also a large concentration of surface hydroxyl group seen, which on immersion in aqueous solution increase in concentration and promotes the absorption of proteins such as integrin and cytokines, which are further important for the compatibility with surrounding tissues, especially bone. So a seemingly passive surface oxide layer actually keeps on undergoing changes in which there is a partial dissolution as well as reprecipitation from a microscopic point of view. So there is a great influence of the environment on the composition of the surface oxide film. Now, when we consider the commercially pure titanium and titanium alloys, there has been deposition of calcium and phosphorus at the interface of such materials with the bone, and even deposition of sulfides and sulfides in cell culture media. So there is a good biocompatibility seen in case of titanium. So how does zirconium dioxide fare in comparison to titanium? Like titanium, they do form hydroxyl groups on the surface upon reacting with moisture in the air and dissociates in aqueous solutions. However, unlike titanium, the PZC for zirconium dioxide is 3.6 to 4.2, implying that the surface is relatively alkaline in the human body. Importantly, lesser number of hydroxyl and phosphate groups were deposited on the surface of the yttrium stabilized tetragonal zirconium, while the deposition of calcium ions could not be confirmed. So this is a very important aspect which we need to consider when we move on to the other aspects in form of evidence later in this presentation. Now, when we speak about biocompatibility, we also should be discussing about allergy or hypersensitivity. Now, when you go across the articles, you will find that titanium allergy or hypersensitivity is raised as an issue for possibly introducing zirconia as a viable alternative. So let's go through the incidences to assess whether this is really a widespread and serious issue, or is it just being is just a fear. So when we look at the titanium levels in our body, you approximately have 50 ppm exposure already, because the titanium is routinely used in fashion products or even in sports wear, especially since it tends to impart a white color. When you place a titanium implant in a patient, that 50 ppm might raise to 100 to 300 ppm. And apart from dental implants, titanium have a various range of applications which are shown in the figure here. Now, there are several published reports which have raised the possibility that this may cause a systemic delayed hypersensitivity or localized contact dermatitis. Now, when we speak about hypersensitivity reactions, they are classified by Gel and Combe as 4 types, where the first 3 types are antibody mediated, and the type 4 is delayed hypersensitivity. So in delayed hypersensitivity, we do see inflammatory reaction, which will be peaking within 24 to 72 hours. And the contact dermatitis is the localized form of delayed hypersensitivity. So much of this evidence for the so-called titanium sensitivity is coming from orthopedic research and not dental literature. We also need to understand that the oral mucosa has a different set of immunological properties compared to skin. For example, it is less permeable and is coated by salivary glycoproteins. For instance, the studies say that at least 5 to 12 times the concentration of allergen has to be present for eliciting an allergic response for titanium. However, we need to note that there are a few documented cases in association with dental implants. But common to these cases are the absence of past history of contact hypersensitivity to metals. One of the good extensive studies which I came across in the literature was performed by Silesia et al. In 2008. So in this study, around 1,500 patients were enrolled, in whom implants had been placed between 2002 to 2004. And of these 1,500 patients, 35 patients were selected. In these 35 patients, there were around 16 patients in whom unexplained titanium failure had happened. And the remaining had a previous history of allergy to other metals, excluding titanium. So these formed the group of 35 patients, and the other were a control of 35 patients. So in the second phase of the study, these 35 patients and 35 controls were subjected to cutaneous and epicutaneous test. So what were the results? Titanium allergy could be detected only in 0.6% of the subjects. So it's an extremely low prevalence. There are studies which have hypothesized that the trace elements of nickel, chromium, and palladium, which are present in these titanium alloys, might in fact be responsible for the documented titanium sensitivity, hypersensitivity, or allergy. And it's not per se the titanium as such. Also, there are diagnostic tests which are frequently discussed about, including patch test, ECT, MELISA, or LTT. So there are studies which have concluded that these have shown inconsistent results in terms of reliability and validity. So this is a recent publication in 2022, the German S3 guideline on titanium hypersensitivity in implant dentistry. So the authors concluded that for reasonable decision making, a patient's clinical symptoms should be regarded as a leading parameter, which are usually expressed by local inflammatory reaction. Importantly, allergy tests such as the epicutaneous test or the lymphocyte transformation test are not helpful in titanium tolerance assessments. In case there is a localized inflammatory response, the implant has to be removed, and you can consider a dental ceramic implant as an therapeutic alternative. So this is regarding the titanium hypersensitivity, an extremely low prevalence, and it's not easy to diagnose in a patient either. So we went through the mechanical properties, we considered the aesthetic, we looked at the biocompatibility. Now the biocompatibility obviously has a kind of effect when we are going through the bone formation, bonding, osseointegration in zirconium versus titanium implants. So we know that osseointegration is defined as the apparent direct attachment or connection of osseous tissue to an inert alloplastic material without intervening fibrous connective tissue. Now, when we speak about bone formation or this bonding or osseointegration, what we need to keep in mind is that it will be majorly influenced by the chemical nature of the material concerned. So we know that zirconium and titanium are similarly placed in the periodic table, but there will be certain properties which will vary, like in form of oxidation rates, the water interactions, crystalline structures. These will vary. And we need to assess whether these properties are the one which are influencing the outcome, what we see in the studies. So the outcome, there are multiple studies which have documented various aspects of osseointegration pertaining to titanium. So I'll be going briefly about the zirconia aspect here. So one of the early studies was done by Akagawa et al. In 1993. So they had conducted a study whereby there was a clinical and histological evaluation of partially stabilized zirconia endosseous implants under loaded and unloaded condition in 4 beagle dogs. So what they found here is there was an appropriate bone implant contact happening in both the cases. However, there was a bone loss in the implants which were loaded early. And that's why the recommendation came that it should not be loaded early in case of one-piece zirconia implants. Otherwise, it can impair the osseointegration rate. So this study could basically establish that there is a reasonably good level of bone implant contact. So the next step was to find whether this could be sustained over a greater period of time. So Akagawa et al. Again in 1998 conducted a study which was comparing this situation between freestanding and the tooth connected, partially stabilized zirconia implant. So what did they conclude? They concluded that one-piece zirconia implants in one-stage procedure could achieve long-term bone implant contact and osseointegration. And they recommended that these one-piece zirconia implants be put for clinical trials. Now, much later, we see Gallet et al. Conducting a study in around 2007, in which biomechanical and histomorphometric comparisons were performed between zirconia implants with varying surface textures and a titanium implant in the maxilla of a miniature pig. So basically, a titanium SLA surface implant was taken, and they were compared to 2 zirconia implant specimens. One set of zirconia implants had a machined smooth surface, and the other set of zirconia implant were made rough by sandblasting. On initial examination, it was found that the SLA titanium surface had a rougher surface, and now the pigs were subjected to extraction of teeth in the maxilla, two teeth in fact, and then they were replaced with these set of implants with the titanium SLA acting serving as a reference. After a healing period, the implant just a minor correction. Initially, the extractions were done, a healing period was allowed, and then the implants were placed. So we had a healing period of around 4 and 8 weeks, subsequent to which there was a reverse talk test done and the values compared. A set of samples were also taken for histomorphometric comparison between zirconia implants and the titanium SLA surface. So what did we see? The surface analysis revealed the highest surface roughness for the SLA implant, followed by rough zirconium dioxide implant, and the least values were found for this machined or smooth zirconium oxide implant. The turned zirconium dioxide implant also showed statistically significant lower removal torque values than the other two implants after 8 and 12 weeks. So to conclude, compared to the machined or smooth zirconium dioxide implant, the rough zirconia implant or the zirconium dioxide implant achieved a higher stability in bone. So this is one of the earlier studies where we see that a roughened zirconia implant is giving a better stability, a better bone implant contact, and better osseointegration compared to a smooth or machined zirconium dioxide surface. In a way, it parallels this journey of titanium as well. When titanium was introduced, that also was kind of machined and smooth. Subsequently, we had different titanium implants being introduced with different features. So this was a meta-analysis of the preclinical studies which were conducted in 2023 by Ramosu et al. So this was basically all the preclinical studies till then were included, and there was an evaluation of the performance of the zirconia implant in comparison to titanium. So what did these authors find? They found that within the limitations, the zirconia implants had a similar level of osseointegration compared to titanium implants. So according to them, there was no difference between the level of osseointegration or bone implant contact observed for both the types. However, there was an important study limitation, and that is always something which we need to look out when we are looking at the results of any study. There was a lack of standardization in terms of period, as well as the surface of the implants which were assessed. Many of the studies did not mention as to whether they were using a roughened surface or a smooth surface, or even if the roughening was done to what level. So there was an ambiguity in that case. So that prevents an appropriate comparison of osseointegration and appropriate result, what could be told. So I'll just telling you about one more study here, and this was again done by Rowling et al. In 2019, whereby zirconia was compared to titanium dental implants in preclinical studies. There's again a systematic review and meta-analysis in 2019. So what did these authors conclude? They found that zirconia tended to demonstrate lower bone implant contact values and reduced removal torque values compared to titanium. However, they mentioned that there is a serious limitation to the observation what they have given. There are various criteria which tend to affect the overall assessment in form of implant loading protocol, the length of the follow-up, loading period, and the animal type. For instance, in this, when they compiled the studies, there were different animal models which had been used to compare zirconia and titanium. So it varied in form of rats, pigs, you had dogs, sheep. So for instance, when they compared the performance of zirconia to titanium in pigs, there was a statistically significant difference in terms of performance. But when they saw or correlated the results in a rabbit model, they found that both performed similarly. Normally, when we combine different animal models, it's always a source of controversy. But the authors did go ahead and combine these different animal models to come up with their final assessment that zirconia does demonstrate lower bone implant contact values and reduced removal torque values compared to titanium. The authors also felt that with improved manufacturing process and the creation of micro rough surface topographies on zircon implants, there is an improved osseointegrative capacity and survival rate. So the previous or older versions of the zirconias which were introduced and used were not as good as the ones which are commercially available now. Currently, when you look at the zirconium implant surfaces, they are subjected to acid etching or sandblasting, and they have demonstrated better bone implant contact and better osseointegrative capacity. So after the hard tissue integration, it will be kind of incomplete if we do not look at the soft tissue aspects as well. So when we look at dentogingival tissues, we know that it's very important. Their presence is quite important for preventing bacterial ingress and infection. So when we look at the peri-implant tissues, they also play a similar role. If there is a poor addition of soft tissue to the implant or implant abutment, that can potentially progress to perimucositis and then to peri-implantitis. So that's why we should always consider taking care of the soft tissues around the implants as well. And apart from the health, it also plays an important role in aesthetics. It's about the type of margin which is given, the position of the papilla, the health of the soft tissues. They all play an important role along with the restoration to give the final aesthetics. So how does zirconia and titanium compare in this aspect? What is the nature of soft tissue attachment here? So studies have established that the nature of soft tissue attachment are quite similar in both zirconium and titanium. The collagen fibers were also observed to be oriented parallel to the implant surface with similar probing depths for titanium and zirconium implants. Now, those were the similarities, but there are a few differences as well. There was a significantly higher content of collagen and a shorter length of the sulcular epithelium around zirconia implant. So around 0.76 mm for zirconia compared to 1.4 millimeter for titanium. Also, the biological width was found to be more 2.85 millimeter for zirconia implant compared to 2.3 millimeter for titanium implants. So the longer junctional epithelium, in addition to the high density of collagen fibers, are said to provide a better soft tissue integration and better resistance to any bacterial ingression, resulting in lower chances of peri-implantitis. So what are the factors or properties which contributes towards this inhibition of bacterial adhesion and plaque buildup on zirconia implants? So they include a range of factors which can be divided into implant surface properties and host response. So the relative bioinertness along with reduced surface energy is supposed to be a major property of the implant surface in zirconia, which inhibits the buildup of bacterial adhesion and plaque buildup. But importantly, we need to look at the host response as well. The studies have documented a low inflammatory response, which is attributed to release of anti-inflammatory cytokines in increased quantity compared to titanium implants. So you have a situation whereby there is less tendency to accumulate plaque, less tendency for bacterial adhesion, ingression, progress, and also a less inflammatory response on part of the host or the body. So this should logically lead to the conclusion that you see less peri-implantitis or less prevalence of peri-implantitis compared to titanium implants. And that would definitely be in agreement with what has been observed in the preclinical studies or in vitro studies as well. However, there are certain differences or certain points which we need to consider here again. When we speak about peri-implantitis in the literature, we see a lack of consensus and agreement on the definition, and that has resulted in varying prevalence rates being published in the literature. In fact, there are contradictory results regarding incidence of peri-implantitis in zirconium and titanium implants. Like I mentioned, in the preclinical studies, there is evidence to say that there is less incidence of peri-implantitis in relation to zirconia. But when we look at the literature, even clinical aspects, we see contradictory results. The other aspect is for increasing the bone implant contact and increasing the osseointegration, we have increased the roughness of the implants. However, when there is gingival or the recession of the tissues around the implant and exposure of such threads, these threads tend to accumulate uh, plaque, buildup of bacteria, and then they tend to encourage the formation of or lead to perimucositis and periimplantitis. Now, this roughness is generally seen to be more in titanium compared to zirconia. Now, what should be our conclusion from this now, since there are so much contradictions regarding the results? There has been a study by Cottinelli et al., in which they mentioned that patient compliance, including plaque control and regular dental follow-up appointments, may be more important in maintaining oral hygiene and preventing periimplantitis, regardless of whether the patient has been treated with titanium implants or zirconia implants. So that should be the takeaway for the clinicians. Just because you place a zirconia implants, you cannot rest thinking that, okay, this is less prone for periimplantitis, considering all the factors which were mentioned before. We need to have a regular follow-up, and the patient needs to be educated well enough to ensure oral compliance. So now this is the important part of the presentation. What is the evidence and what are the recommendations based on recent studies? The previous part of the presentation gave you an idea about the essential differences between these materials and some evidence based on preclinical or in vitro studies. So now this set of evidence has been taken from a study done by Duan et al. And published in 2023. So the first aspect is about the success and survival rate. Now, when we speak about a success rate over a 5-year period, we expect a greater than 85% for the maxillary implants and a greater than 95% for the mandibular implants. Now, what the authors have stated in this study is that the success rate of zirconia implants are significantly lower than that of titanium implants. The survival rates were also low, but they were not statistically significant. Now, what were the reasons? There were technical complications seen in form of occlusal chipping, and these were attributed to variations in manufacturing methodology. So, according to the authors, the manufacturers may be the main contributor to the extreme heterogeneity in survival and success rates among the randomized clinical trials or cohorts. And that brings us to the original point, the point which I mentioned before, that when you are using an implant, whether it's in this case zirconia, we need to ensure that the manufacturer has an established R&D process on the methodology and has data on the performance of the implant. Now, this study also observed that the zirconia implants had higher failures or prosthetic failures, especially in the posterior region. So they recommended that the zirconia implants not be used in the molar region. Now, what is this other evidence? There was a marginal bone loss comparison between zirconia and titanium implants, and it revealed a favorable result for titanium. Now, this is a bit incomplete because they stated that overall titanium and zirconia performed similar in terms of marginal bone loss, but when they included a study done by Ostman et al. In 2014, including overdentures, the titanium implants the zirconia implants did not fare well. Now, what could be the reason? The reason is that the occlusal forces which a single crown might be subjected to, or that implant under a single crown might be subjected to, is much less compared to an implant which is subjected to forces under an overdenture. So the recommendation of the authors was that the overdenture on zirconium implants have additional risk but no benefits, and they should not be recommended in any clinical setting. In any cases, only in cases where there is a documented titanium allergy should the clinician go ahead with a zirconium implant to receive an overdenture. The next evidence is pertaining to periodontal probing depth, and here they found comparable results under normal mucositis mucosal conditions, and significant difference under mucositis conditions. So if it's a normal mucosa, the periodontal probing depths were quite similar, not statistically significant. However, if it's a mucosa exhibiting mucositis, the periodontal probing depth showed variation. So what is the recommendation of the author? They said that the zirconium and titanium implants can both achieve healthy and stable soft tissues, but zirconium implants may compare favorably with the mucogingival findings reported on patients exhibiting mucositis conditions. Then, as we discussed before, there were contradictory results regarding peri-implantitis for zirconia and titanium. So the recommendations of the authors were that the patients need to have a good oral compliance and a supportive periodontal therapy program to avoid bacterial accumulation and implant loss, regardless of the fact that they were treated with titanium or zirconium. Now, the evidence and recommendations pertaining to the pink aesthetic score. Now, initially, I mentioned that the clinicians and the patients have a view that being a ceramic material, zirconia is a very aesthetic material. So this also assesses the pink aesthetic score of both the implants or both the set of implants, titanium and zirconium, and both of them were found to be acceptable. So the authors recommended that in cases with a thin gingival biotype, especially in the aesthetic zone, zirconia implants could be considered to be a better choice. So it means or implies that there is nothing wrong with titanium as such in terms of aesthetics. Better treatment planning is required. A meticulous planning is in fact recommended, and factors such as smile line, gingival biotype have to be evaluated. Any augmentation procedures in terms of hard or soft tissue should be considered, and they should not be ignored. Now, a few set of recommendations are based on an evidence from another study which was published in 2024. Now, there is a greater tendency for the clinicians to use a zirconium abutment along with a titanium implant in the anterior region. They feel that it will impart or combine the advantages of zirconium with titanium. It will give a better set of aesthetics. But there is evidence to show that zirconia abutments associated with titanium implants showed significantly higher values of wear at the connection interface. Now, what is the reason for that? We know that there is a difference in modulus of elasticity between these two set of materials. So we have titanium with a lower modulus of elasticity and zirconia with a higher modulus of elasticity. So even though the titanium can undergo an elastic deformation, the zirconia implant will resist it, and there might be a greater wear at the interface between these two materials. It will not be similar to how a titanium abutment will be placed on a titanium implant. So the other finding in this study was that this wear will vary depending on the geometry of the connection. If you have an internal connection implant, the wear will be more because the external connection will ensure a greater surface area over which the stress will be distributed. So the recommendations of the authors are that in case you plan to use an internal connection treatment, and you're providing a two-piece zirconia abutment with a titanium abutment or tie base, will be better. It will ensure a better adaptation and preservation at the implant connection surface. So go ahead with a zirconia abutment with a tie base to ensure the less wear of the interface. The other important evidence is that milled zirconia abutments showed 3 to 7 times greater misfit than milled titanium abutments. And what is the reason? Subsequent to milling, it's subjected to sintering, and this sintering process results in shrinkage up to 25%. So the recommendation is that the necessary dimensional increase of the milled structure should be done during the planning so that can account for the shrinkage post sintering. So these two set of points are equally important when we consider about integrating the zirconia abutment with an existing titanium implant. Now, towards the end of my presentation, I would be going through the other set of evidence which was presented at the 7th ITI annual conference in Lisbon 2023. So there were a set of consensus statements and recommendations which were given. So as I have mentioned before, there are a set of zirconia implants which are no longer available or commercially being used. And there are newer set of zirconia implants which have been introduced into the market and are commercially available still. So there were a set of 6 consensus statements. And the first important statement, the first consensus statement mentioned that the available data, there can only be a set of conclusions drawn regarding to one-piece zirconia implant. According to the people or the the researchers and the clinicians who sat down for this consensus statements, they felt that the data is available for two-piece zirconia implants is insufficient. The subsequent statements mentioned that the new commercially available zirconia implants have a better survival rate than the ones which are no longer in market and are at par with the titanium implants. Other equally important thing is that the marginal bone loss which was seen with the new commercially available zirconia implants was just 0.67 millimeter, which is much lesser than around 3 millimeter values which were observed previously. The fracture rates for the one-piece zirconium implants were also as less as 0.2% with the new commercially available zirconia implants. So these were the important consensus statements which one can go through. And what were the recommendation? The recommendations of the ITI body was that the one-piece zirconia implants for single crowns and 3-unit implant fixed dental processes only. So they did not recommend any versatile or diverse applications of zirconia. They have they have recommended that the two-piece commercially available zirconia implants be used with caution since there is insufficient supporting data, and the one-piece zirconia implants be used only for single crowns and 3-unit implant fixed dental processes. So this shows that the body is quite cautious when it examines the available or existing evidence, and we still cannot say that zirconia is as versatile or dependable as titanium, which is an existing gold standard for any implant material in the market currently. When we speak about a single piece implant, they also recommended that the difficulties relating to submucosal prosthodontic margins, like removal of cement excess, be considered, so that the health of the peri-implant tissues are not compromised and they can be maintained. So to conclude, zirconia was proposed as an alternative to address the perceived drawbacks with titanium implants. However, on going through the existing literature, the data, we see no clear superiority in relation to mechanical properties or osseointegration. We do not see the rate of allogenicity or hypersensitivity to be alarming in case of titanium implants, which warrants action. There were definitely an aesthetic benefit which is there with zirconia implants or abutments. Now, clinicians who are using zirconia abutments with tie base will have a better survival rate. I think I need to rephrase it. When you use a zirconium abutment with a titanium base, that will show a better survival rate since there is less wear at the junction or the interface. So zirconium implants can be established as a viable alternative only after future studies with greater methodological rigor, interventions, and longer follow-up time determine the safety, indications, and drawbacks for its use. So thank you one and all for your patience and listening to this presentation.
Thank you for your contribution, Dr. Sivaraman, for your very interesting lecture and for your contribution in Elsevier book project. Thank you.
Thank you,
Namaste.
Professor. Thank you. Namaste.